Good afternoon, good morning, everyone. Thank you for joining us today. My name is Lily Armstrong. I am a senior manager with NASTAD's Drug User Health Program. I am glad to be joined today by my colleagues, Amanda Muller, Laura Pegram, Alika Opadehe, and our colleagues and wonderful consultants, Maya Joe-Simpkins and Eliza Wheeler from the Opioid Safety and Naloxone Network Buyers Club. We are all joined today with you all to talk about naloxone supply in the United States and to strategize how to best keep SSPs and other harm reduction programs that are working directly with people who are using drugs and best able to respond well equipped with naloxone going forward. We will have some updates to share with you all. We will be going over a memo that NASTAD recently put out about managing naloxone supply. And we will open up the floor for lots of questions and discussions. We look forward to hearing updates from you all about what's going on and what you're seeing in your communities. I am going to pause for 1 minute. We are going to let some more folks join us and make sure everybody is settled before we get started. Thank you again for being here, and please feel free to drop any questions in the chat box. As a final note, you already heard this meeting is being recorded. We will share a recording after the call. Please let us know if you have any kind of problems or questions related to disseminating the recording.
All right, so do we want to go ahead and just jump in, I guess, here? Thank you, Lily, for that intro and overview of where what we're hoping to get out of today, and really just thinking through, really appreciating this group of very brilliant folks who have pulled together a lot. There's been a lot of work and coordination and organizing between us and them and a lot of other partner organizations and federal agencies. So really just glad to be helping to host this today and provide a platform to, to hopefully, get some good information out there in the world. So I'm going to pass it over to Eliza and Maya to take it off. And yeah, appreciate y'all.
Hi, everyone. My name's Eliza. I'm going to give a brief overview of the OSIN Naloxone Buyers Club, which is what we're sort of focusing on today. In terms of the naloxone shortage, Maya's going to go into some more detail about the naloxone shortage in a minute. But the OSIN Buyers Club, just historically, is a group of currently 108 programs across the country. We have programs that belong to the Buyers Club in 39 states and DC. We have been a coordinator of low-cost generic injectable naloxone purchasing since around 2013. The Buyers Club was originally organized by and coordinated by Maya, myself, and Dan Bigg from Chicago Recovery Alliance, who was the first person, and CRA was the first program to negotiate low-cost injectable naloxone purchasing. So over the years, we've added many programs. We focus on adding nonprofit organizations who are directly distributing naloxone to persons who use drugs and other potential community bystanders. Currently, the Buyers Club purchased about 1.3 million doses of generic injectable naloxone last year. Which is primarily distributed through a network of harm reduction programs throughout the country, with a focus on making sure that naloxone access for people who use drugs is prioritized. So the current shortage that Maya's going to go into more detail about in a minute is affecting specifically this group of programs, and also programs who receive free generic injectable naloxone through direct relief. So Maya and I are not affiliated with Direct Relief, but we are usually in pretty good communication with them. And so this shortage is also going to affect people who get naloxone from Direct Relief, but we won't speak specifically to what their process is right now. But Maya's going to talk a little bit more about the current shortage and how that's affecting the Buyers Club.
Hey, thanks, Eliza. I'm just gonna do some broad strokes of specifics more currently. The Ocean Naloxone Buyers Club group has been around for a while, but we've been paying very close attention to annual purchases and distribution for the past 4 years. And what we've seen in 2017 through 2020 is that this group of a very small number of organizations, there's actually only 108 organizations that are part of the Buyers Club. There's some inclusion criteria. It has to be a harm reduction program that promises to give naloxone for free directly to people who use drugs. Has to be a nonprofit or have a fiscal sponsor, have to have a physician or somebody with a DEA or a nurse practitioner or physician's assistant with a DEA number to sign on to it, and then are able to directly purchase naloxone at a considerably reduced rate. So this group of 108 programs in the years 2017 through 2020 has purchased 3.7 million doses for distribution. And we've seen just an incredible increase in, I'm just focusing on the past 4 years from 2017 to 2020, just because those are the numbers we have that are really nice and clean and reliable. It really is it's an informal group, and like Ocean it's a Google group, right? It was formed in 2007 or 8 as the Naloxone Access Brain Trust many years ago, and so it's we're just an informal group of folks, and Eliza and myself and formerly Dan just volunteer coordinate this. So it's not necessarily any more complicated than that, but in our good solid Eliza eyeball to detail numbers are from 2017 on. So in 2017, we purchased collectively around 500,000 doses. In 2018, it was closer to about 875,000 doses. In 2019, it was the first year that group collectively purchased and distributed over 1 million doses. And then from 2019 to 2020, which is kind of key important pandemic time period, the amount purchased increased by about 30% to 1.3 million doses. And so I want to just contrast that a little bit to the amount of naloxone that has gone out through pharmacies during the same time period and during the pandemic. That amount decreased by over a third, whereas the syringe service programs and harm reduction programs that are part of this small but mighty collective of organizations increased by about 30%. So I know that we have just seen last Wednesday new data out of the CDC, which is really problematic. And the reason I think it's really important that we focus and prioritize on this particular group of organizations and their troubling current lack of access to naloxone is that this is the backbone of the naloxone that goes out in the entire country directly to people who use drugs. And it's one of the major floods. And not only are there 108 organizations that do a lion's share of the naloxone distribution to people who use drugs, many of these organizations informally or formally, but oftentimes informally partner with other agencies or mutual aid groups that sort of expand the reach of this group. So the other thing that I think is important that are some results that Eliza and I are working on and other colleagues are working on writing up is that this group of organizations that get naloxone, they purchase naloxone through the Buyers Club, and then they also get some naloxone for free donations from Direct Relief. That this group of organizations is, I guess I could say, wildly underfunded. We did a survey that is the results of which are forthcoming that shows us that less than half of this group of organizations has received any federal funding whatsoever for their naloxone and overdose prevention efforts. And so I think that really, the combination of supply interruptions from our main supplier that offers naloxone at an affordable price, combined with COVID, really sort of pulls back the curtains on the dire situation that these workhorse organizations are in. And it also gives us lots of opportunities to think about ways that more well-funded and stronger infrastructure organizations like health departments might be in a position to support the work that these organizations have done. And I just want to repeat that it's, you know, a 30% increase when literally the health departments in the communities were shut down or attention was focused elsewhere. These were agencies that were ramping up efforts with overdose prevention. So I'm sure that there's lots of thoughts or questions. It seems like Eliza has one more thing to answer.
Just one more thing. I just think it's important to note too that the shortage was announced and the Buyers Club is currently over 250,000 doses of naloxone on back order. So that is, so collectively the programs have put in 250,000 dose orders since the shortage went into effect. And so that's 250,000 doses and growing that is not currently getting out into the community.
And to put a very practical and finite number on that, the 250,000 doses that we are back ordered probably results in just north of 100,000 naloxone kits, which translates based on the research and evidence that we know to quite literally 11,000 lives. So that's what the actual drill down of that 250,000 dose back order is. And we have, I'll drop a link in the chat box that, but I also just want to say that the anticipated timeline for resolving this manufacturing glitches is the end of the year at best. So at this point, I think we'll pass it back to our NASDAD friends to discuss some of the specific recommendations.
Yeah, thank you, Maya and Eliza. Hi, everyone. I'm Amanda Muller. I'm on NASDAD's Drug User Health team. So I put a link in the chat a little bit ago that is a link to our recommendations if you want to pull them up or reference them later. I'm just going to kind of briefly go over them and then we can open it up for questions and discussion. But we did kind of break these recommendations down into like recommendations for federal partners and for health departments at more the state and local level. So they're very similar, but there are some like nuanced differences between the two. So going to recommendations for federal partners, our first one is kind of, and we did develop these in consultation with Maya and Eliza for obvious reasons, but negotiating the price of naloxone with manufacturers is certainly one of them that I think speaks to like a much larger issue of naloxone access and pricing and has been a constant issue for quite some time. So that is one of them, and or making bulk naloxone purchases at the federal level that are only for syringe service programs and harm reduction programs for access. More in like the nitty gritty of spending down funds. So from the federal partner side, increasing and ensuring flexibility with folks being able to spend their money. So in many instances, if this is funded through a grant, if the federal fiscal year or the state fiscal year ends on like June 30th or October or September 30th or whatever the timeline might be, depending on the grant, we wanted to avoid a situation where folks were purchasing more expensive naloxone products in order to spend their funds by like the end of June, July, September, whatever the date is, knowing that this will get resolved and they will be able to access, lower cost generic injectable naloxone, at a later date, meaning they could buy a lot more naloxone, which is like the volume that is actually needed to distribute to people who use drugs. And so asking federal partners to allow for like no cost extensions or carryovers where maybe they wouldn't have previously, depending on the grant, to allow for programs to like continue to roll this funding over and purchase lower cost naloxone once this issue is resolved. And that kind of goes hand in hand with our next one, which is basically advising grant recipients to consider risks and benefits of purchasing more expensive naloxone in the meantime. I think there's definitely probably going to be instances where like that is going to be necessary, at least as like a short-term solution for maybe a small portion of funding, but really wanting to avoid, spending down the rest of somebody's grant just to meet like a budgetary deadline, and essentially buying less naloxone than we'd be able to fund if we were able to get it at a lower cost a little bit later on. And the reason we focus on that a lot is because like syringe service programs and harm reduction programs that are doing community-based overdose prevention, like distribution directly to people who use drugs, do save the most lives and reduce overdose rates the most out of other types of naloxone distribution programs. So really needing to prioritize those types of programs for naloxone access, as opposed to other programs like treatment providers, law enforcement, other organizations that do still engage in naloxone distribution and still have a role. But if we're prioritizing and kind of triaging who is, in most desperate need of immediate naloxone access, it would be syringe service programs and harm reduction organizations. So urging, single state agencies that might be controlling some of these funds at that level, or health departments to prioritize naloxone access and supply and funding to SSPs and harm reduction programs. In terms of recommendations for health departments, similar, but I think there's some more like coordination and stuff that we've come up with for them to do. So assessing the needs of naloxone distribution programs in your area from like a state and local health department level could be very helpful. So reaching out to naloxone distribution programs in your jurisdiction, again, especially SSPs and harm reduction organizations, to assess what their supply, naloxone supply currently is, if they're running low, and what their projected needs might be, so that we're able to then coordinate like naloxone sharing, supply sharing within your jurisdiction. If there are programs that aren't distributing as much and are able to, give some of their naloxone to an SSP that's running low in the meantime, that kind of stuff, more of like a mutual aid network situation. From the state health department level as well, if they're able to ensure flexibility with funds used to purchase naloxone. So similar to the federal recommendation of allowing no cost extension and carryovers, if that can happen at the state level as well, for some of the funds as programs are navigating the situation, allowing there to be like no cost extensions or carryovers, so programs can purchase lower cost naloxone at a later date and buy a lot more of it and be able to distribute a lot more of it. So similar for, again, advising to really think about and weigh the risks and benefits of purchasing more expensive naloxone in the meantime, if it's simply to spend down grant money and meet a budget deadline. And as you're assessing the needs of naloxone distribution programs in your area, prioritizing naloxone for SSPs and harm reduction organizations. So I am going to pause there. I don't know if anyone else from my team wants to add anything, and then I think we can also open it up for questions and discussion. Laura, Lily, no.
Yeah, no, I mean, I think you summed up really, really nicely, Amanda. And yeah, the recommendations that you all put together, I think are short, sweet, simple, to the point. We're really hoping this session is just sort of a state of the situation, because, I think there are a lot of knee-jerk things, like initial impulse things that at a lot of different levels, federal, state, and community-based group, right? And so we really just wanted to, put out, just some recommendations about how to navigate this in a way that, will help this larger coordination that Maya and Eliza are trying to, navigate with direct relief and with the manufacturer themselves, really, I think, as we started having these conversations, a tone of, stay calm, like, the thing that we need to do at this point is actually acknowledge the problem, figure it out, but also not be impulsive in some of the ways that we that you all might be able to address some of these things, because it is not great news, and we have a lot of expertise and history here on this call to help navigate some of these situations. So glad to open it up for questions. Yeah, Maya, go for it.
Could I just add an additional level of specificity with the recommendation in particular to prioritize naloxone for syringe service programs and organizations that give naloxone directly to people who use drugs. This is, Laura was, referencing that we do have some expertise. There was a naloxone shortage in 2012 that we kind of collectively survived by reallocating resources, identifying which organizations had stockpiles, identifying which places had naloxone that they were not quite able to push out the door to people who use drugs quite as effectively as syringe service programs. And so just to be real explicit especially for folks from state and local health departments, the entities and the agencies that have the loudest voices around needing naloxone are oftentimes the entities and agencies that are less likely to use the naloxone during an overdose. And I think that that's a really interesting tension that people may have to navigate and think through. But the recommendations that show prioritizing the organizations that work with people who use drugs is paramount. And even though some of the other organizations like law enforcement or parent groups or schools and libraries oftentimes have a stronger voice on a policy level and on a respectability politics level, it's really important that we don't respond necessarily to that kind of freak out from entities that have entitlement to their loud voice and big requests over syringe service programs that is where the naloxone is most effectively placed in the context of preventing fatal overdoses. So I just wanted to be real explicit and overt in that particular recommendation.
Yeah, no, thanks, Maya. And I think, the extra layer there, the one bullet that I think, is worth noting, that all of those entities have much larger budgets, right? And so, are probably much more able to handle extra costs compared to purchasing naloxone, different types of naloxone from different manufacturers. So added level there. I see this question from Ella about TA in the form of oops, I muted myself. That's a good question. Actually, I don't know that we have a formal template for that, although I don't think that it would be that hard to put it together. I think that my first, it can be pretty simple. One, if you have SSPs in your jurisdiction that check just how is your naloxone supply? And the way that I've been asking programs is, are you currently out? Do you have enough to last a month? Do you have enough to last 2 months? And then do you have more than that? And so I think that just that. However, I am aware that there are many jurisdictions that have either underground, quasi-underground, or don't ask, don't tell type syringe service programs in their vicinity. And in that case, if you're from a jurisdiction where you don't think you actually have a syringe service program, that might be something that we might want to have an individualized, maybe offline conversation to see if it's possible that we could either make some connections or act as sort of third-party communicators if there are situations where the legal situation is such that it puts people in a position. So Ella, does that make sense to you? Does that sound about right?
Yeah, Maya, so some people in here know and some people don't. I walk in two worlds. I have Alabama Harm Reduction Coalition in one of the most resistant states in the union. So I do deal with the underground stuff, but I also work for Philadelphia Department of Public Health. And my question came in really because we can readily identify our SSPs, of course. However, we have organizations, much like my organization in Alabama, where we get no financial funding. And so we can't afford to buy a whole lot. And so I guess my question for the forum is maybe some questions that would ferret that out within Philadelphia as well, because we do have those organizations here as well. Whereas like our largest syringe exchange, they get a large amount of federal granting. And some of these smaller organizations get none. And so I was just wondering if that were a form that had been created. And if it hasn't, that's fine. It's easier not to recreate the wheel. So I appreciate your answer.
One thing that I don't think has been explicitly said, sorry, I'm going to jump in one more time here and then I'll be quiet for a while, is that the supply interruption applies specifically to generic injectable naloxone, and it doesn't apply to the considerably more expensive but not supply interrupted Narcan nasal spray. And as far as my understanding is that the Evzio auto injector is also not interrupted, but I don't know any SSPs that are spending that kind of dough. So I just wanted to be explicit about that. And I also feel like maybe there's a great opportunity to crowdsource this question that you have, Alice, specifically within this conversation, within this meeting, if there's time for that.
I think it's also important to say that for states that have large supplies of nasal Narcan, that they're administering maybe through SOAR grants or whatever the current name of that is. Sorry, been out of the loop for a year. But states that do have a large supply of nasal that they are allocating to programs across their states, they need to be making sure that they're prioritizing filling requests for SSPs and others who are going to be affected by the generic injectable backorder. Many programs receive some nasal from their states, but are only able to scale up to the amount of distribution that they need to be doing using supplementing with cheap generic injectable. So lots of the biggest distribution programs are giving out both and are historically not able to get the amount of nasal from their state suppliers in order to actually scale. So, when we're talking about scaling in a big city, we're talking about, 10, 20, 30,000 doses a year. And so that's millions of dollars worth of nasal. And so if your state does have such a supply of nasal, it would be good to do some advocacy with whoever administers those supplies to make sure that they're prioritizing filling and completing filled orders for SSPs.
Yeah, so thanks everyone, and definitely feel free to chime in with other questions or type them into the chat. Certainly, this is a lot to take in. NASDAQ works, with a variety of different agencies and entities. So even as we're talking right now, really, one of which, the primary one of which is state health departments and sort of state level health systems. So even thinking about using the suggestions that we created in partnership, as well as this recording, to really maybe do some in-house in-state advocacy for emergency funds, for just different types of ways to different levers to pull, is what I'll say, right? It does seem that certain jurisdictions, if and when made aware of this, would certainly be able to find some extra, dough to put behind some things, and might create, and I think that goes for federal partners as well. Is there a space to be raising awareness around certainly the increased need, and also the situation that that is going to lead to increased need for extra money to purchase adequate supplies. So really just thinking strategically about, what kind of levers do you have, and now would certainly be the time to be strategic in pulling them, so that would be a consideration as well.
Christopher Thomas, Sonoran Prevention Works. Is there assistance? I think that you and I talked about this, Maya, but is there assistance from any of the more national agencies to, I don't know, write a brief or something like that to state agencies? Like if we have a Caltrans state agency, does anybody have any ideas about like national organizations that could lean in on that and say like, this is our best, practice? So.
Yeah, so Christopher, thank you. And Arizona, yeah, I've been on a call about Arizona 2 or 3 times a day. But yeah, so the recommendations that we put together made a good effort to kind of give a broad overview of what is currently the issue right now, as sort of a primer. So I would encourage you to check that out. I think it might meet kind of what you're talking about here. Certainly, this recording will be made available. You in Arizona should. I mean, Ricardo might even be on here, but there are certainly folks at the state level who have received the memo that we sent out and those suggestions. Yeah, glad to talk through if that's missing something. Feel free to reach out directly, and we can talk about either creating a separate standalone thing or making additions to that. So
I'll jump in again real quick if possible. So I know that some of us have been able to access cheaper Evzio kits, and that was fantastic. But I'm just throwing this idea out there to the group. I don't necessarily have it worked out in my mind, but it would seem to me that given the amount of time that those were being developed, that maybe there's a large stockpile of those sitting around somewhere collecting dust and maybe are expired. And if anybody has any ideas about who we should approach about that, and attempting to get those expired kits either for free or for a market discount would be helpful.
Yeah, I mean, I think you bring up a really good point, right? That and I think Maya, Eliza, other members of OSNN have done, I mean, a lion's share of, I mean, it's just been an enormous lift to do this sort of national level coordination, even with the programs that are just engaged in the Buyers Club. And I think part of what I'm hoping health departments and federal agencies and partners will take away at this point is that a lot of that coordination is probably going to be the easiest lift and most intuitive to happen on the local and state level. And that's like a really great place for health departments who, can help do some of that coordination, either in identifying, who has it, who needs it, how to share, who has the resources. Does your health department maybe have the resources to help with some of that shifting between programs in state, or, some more active outreach to other types of service organizations, thinking about FQHCs and different AIDS service organizations, their networks, right? So I think part of our hope here is to kind of plant some seeds at the health department level and the different agency sort of levels. And I think it would be interesting, since we have a little bit more time, we have a good mixed group on this call from what I can tell, the names I know. I'm curious if any health department or federal agencies who are around have would be willing to share any thoughts they have about what feels possible, or what are some things that you are trying in your jurisdiction?
Are you okay with me going, Laura? So, as I said, I work in the city of Philadelphia. I'm the harm reduction program manager. And one of the things I have been able to do because of what's going on is to use that as a motivator for emergency funding through the state to allow for them to send us more doses of actual nasal, so that the nasal and the IM that we have we can up our distribution to our partners. And that was, I mean, that's been very fruitful during this time. Since all of this happened, we've been able to procure almost 20,000 new doses that we wouldn't have gotten. And I do that by using our epi data, things of that nature, saying, you know, our overdose surges, put that all in the email succinctly. You know, also get some statements from our partners saying this is what we're experiencing. And so I've been able to procure more nasal to the point, and this is when she said the end of the year, because I was still thinking end of July, I'm like, we're going to make it, we're going to make it. The end of the year is even pushing it for a program such as Philly. I mean, that's just the truth of the matter. But that is one thing I have been able to do by building a relationship with the state, is to be able to get them to send us more Narcan by giving them our surge data and things of that nature, and actual quotes from some of our partners that are also struggling. I don't know about you guys, but our state also just started a state portal, which will allow for us as the Department of Public Health to give a set amount of kits to each one of our partners, and then relay to them a state portal where the state corresponds with me to make sure how many they've gotten from me. And then we come together and they, like, let's say our largest SSP, and I won't say any names, we were able to get them 7,200 more doses last month. And so I think a lot of it has to do with knowing that your state has that kind of funding and holding their feet to the fire on how to be able to access that for the individuals, because not only is the public health, you know, dealing with surges, we also can prove that our partners are dealing with even more surges. And so that's been very helpful in our journey. And so far, I've been able to hold off on ordering any IM naloxone to help the smaller people who are trying to do so. Since this has started, I don't know that I'll be able to do that through the end of the year, but that's just my thoughts on how it's been working for us.
Thanks. Thanks, Ella. I do see that Tom Hill has his hand raised, and we'll come back to other state agencies, local agencies that might want to share. Hey, Tom, good to see you.
Hey, you guys, my computer is really slow, and I often have to go off screen in order to have things not freeze up. So I apologize for that. So I'm currently at ONDCP. And so I've talked to Maya and with Daniel Raymond about this issue, and so have other staff members. And so one of the things that I was thinking recently was, there's SOR funds and there's American Rescue Plan funds that go to the states. And so I talked with some folks at SAMHSA about how maybe some of that money could be used for, it would be used for the nasal, at least in an emergency capacity, and to be made available. The issue is that SSAs usually don't know health departments very well, and they usually don't know SSPs very well. So I'm talking with the folks at SAMHSA. I can't promise anything, but trying to see if some of that, if they can either work through the SSAs or the regional administrators to free up some of that money to be used for nasal, for SSPs in an emergency capacity. So no promises there, but sort of exploring that channel. What I sort of need from you guys is to have organize the SSPs to, and we've talked about this already in this call, organize the SSPs to contact the SSP, SSA, and to familiarize themselves with who they are, what they're doing, and what the need is, so that there's at least a familiarity and recognition that the money that the states have could potentially go directly to the SSPs or through the health departments, however that works. So just wanted to put that in your ear in terms of one idea that the issue would be that the naloxone would be nasal. But if that's what's going to work on the ground in an emergency capacity, time limited, then that's what you got, right? So open to any sort of suggestions or ideas or just observations about how that might work. Thanks.
Yeah, I appreciate that, Tom. And you know, I think that is certainly embedded in the recommendations that we put out. And I, you know, also want to say, I think we crafted that in a way that it is bi-directional, right? That, you know, certainly, you know, we need to be putting, you know, pressure on, you know, communication, better communication at all of these different levels. And so, you know, again, NASDAQ primarily works with health departments, but because we work with drug user health programs, we do a whole lot more work with SSAs than a lot of the rest of the NASDAQ team overall. You know, and I think, you know, because I certainly appreciate that and the idea of allocating different parts of COVID response money, and that certainly makes sense. Back to the point I think Eliza and Maya made is that even before this shortage, right, we already needed a whole lot more resources going towards naloxone purchase just to make coverage, right? And so, you know, really hopefully finding ways to be strategic at all of these levels to work to try to negotiate costs down, because, you know, there is certainly a lot of emergency response monies that could be allocated here. And I just worry that if it's sticker price for even, you know, for the nasal, that we still probably might not reach saturation. So, you know, we are certainly at our organization doing some real thinking and communicating with other producers to see if there are ways to you know, work to help negotiate some costs for some of the other types of naloxone, similar to the you know, the pricing task force for HIV medications that we have navigated over the years. So, you know, hopefully more to come on that, but certainly appreciate, yes, the loosening, the suggestion for single state agencies to be loosening and allocating different emergency response funds here.
I also just wanted to kind of what we were talking about before in terms of like expired naloxone or close to expired naloxone. If folks are not already kind of engaged in that like network at the state or local level, but you know, when hearing about like, should we buy more nasal in the short term, it just, there's so much close to expired or expired naloxone at like law enforcement agencies specifically, and also treatment providers and other agencies. I used to work for the SSA in Florida, managing our naloxone program, and then like worked with our Department of Health, which funded it for law enforcement and EMS. And like the amount of expired naloxone was wild. And we had a pretty good system where we were able to convince folks to give us expired that we would like use for training purposes or redistribute or, you know, whatever. And be able to give to SSPs. So, you know, I would really encourage folks to be engaging in that type of, or have that set up for future issues that come up as well. So that when something like this happens, it's kind of already like in place and we're already getting, you know, some places might not be comfortable giving you expired naloxone if they think you're going to distribute it, but you can. I know Alice Bell had always recommended like having programs or agencies give you naloxone that's going to expire in like 3 months or in a month or in 2 months, and give it to programs like SSPs that are going to be able to distribute that very quickly before it expires. And then the state can replenish that agency's supply because that's probably already going to happen. So just like really encouraging folks to, you know, engage in that type of network as well. It's hard to want to buy like a bunch more nasal when there's probably a lot of unused ones that might just like get thrown away. So I'll pause there.
And just to Maya's point in the chat about ordering other generic injectable products, which is a possibility, you just won't have a price arrangement with them, and you'll pay market price, which is about $19 a dose at this moment. So 19 is better than 75, but still not great.
And I did see Kristen from HRC put an ask out there, but yeah, so I think that you are aware that NASDAQ, in partnership with NHRC as well as other TA providers through the National Harm Reduction TA Center, have been in good communication with this larger group. So thinking through whether we might want to work with you all to do some office hours has been brought about. At this point, I think let's think about sharing what we have, and then we can find a way to connect offline and assess next steps. This is certainly, this is the beginning of what will be, an ongoing effort here.
Hey, Eliza or Laura, do any of you know if there's a way to, because I will say in the state of Alabama, the health department won't give you the doses that are about to expire or even have, they get destroyed. Is there a way to motivate these health departments to do something different?
And I think you're talking about county level health departments.
I am.
Well, would they allow you, would they distribute it to programs prior to it expiring? So like a few months before it expires? I know that some health departments are not going to give out naloxone that is already expired, knowing that a program might distribute it, even if you say it's, not for that. But is there a way to set it up with them so that they give it to you a few months prior to it expiring?
First of all, they're very tight-fisted to begin with. And they're more than welcome to give me 900 kits to go train law enforcement, but won't give me 900 kits to go give to other individuals. Actually, it's still illegal to hand it out in Alabama unless you're a doctor, nurse, or pharmacist. So I have to take a pharmacist into the field, my team does. So yeah, and I happen to know that there was about 2,000 kits expiring, and I was told no. So I'm just wondering if there's a way to press on or motivate them to do something different.
I mean, there's a lot to say about that. There's plenty of data and research and advocacy that has been circulating for years to support the redistribution of expired or near to be expired naloxone. I mean, you can try that route. There have been policy briefs. There's been, research on that shows that naloxone is still viable for 30 years after it expires. There's been a lot of work for many years done on this issue because of the vast amount of naloxone that is wasted by purchasers who are buying it and then misappropriating it to different places that don't need it.
Yeah, I mean, I always want to say research sell, but and I hear you. Ella, one thought, and we could touch base on this offline. If you could find a hospital system or something like that to be your messenger, say like, oh, we want to do the state level coordination among health departments, county and local health departments, to help gather the nearly expired naloxone because we have priority people. Maybe we need to talk about who's your messenger to be sort of like the funnel umbrella person, and then have a good relationship, and then they can give it to you. But that's just, one thought.
Yeah, unfortunately, I have the public health officer in my pocket, and he still can't make headway. So I was just wondering if anyone else had, any luck with any similar situation. Yeah. Thanks, though. It's just the way it is some places.
Yeah, that's tough. And another note, I guess, is that we partner very closely with NACCHO, who's the sort of equivalent to NASDAQ for public health departments at the city and county level. So we'll make sure they are already in the loop about this, but we'll make sure that they have these resources to hopefully put some pressure. And yeah, Alabama.
And can I, this is not just Alabama. In fact, I would venture to say that probably every single state in the union has at least one municipal health department that is making similar choices. And I mean, in addition to making my head explode, it's counter to what the research tells us works, right? But I think this is another really stark example of the way that naloxone distribution programming has drifted away from the actual model upon which the life-saving evidence base is rests on. I mean, we can't expect to give that many doses of naloxone to groups outside of people who have direct contact with people who use drugs and see the overdose death rate reduced. And it's not a fair ask of somebody in your position, Ella. I feel like this really is something where peer-to-peer communications between health departments need to happen. Funder to, state, federal and state to municipal health department communications need to happen. There really is. I mean, I would go so far to say is that it's unethical to prioritize naloxone purchase beyond, without ensuring that people who use drugs groups have first access. And so I feel like that is something that government peers can have conversations with. It's also a role for media to expose these kind of situations, because it is, because of everything I just said. But another thing that I'm aware of is that some agencies have positioned themselves as naloxone disposal services. So that's one thing that I've heard of in some county or in some states. And some of I know of at least two off the top of my head that I will get their permission for before I say out loud. But one of the entities that frame themselves as a naloxone disposal service had developed a bunch of legal liability exemption language that made the health department feel a little bit more comfortable. So maybe we could have a conversation offline about that, or if there are other entities in this call that feel like something along those lines might make sense, perhaps that's a more targeted conversation to have it at a different point. So
I love that. Love the loopholes, man. Love them.
Oh, Maya, there's a question from in the chat about the media plan. Do you want to talk about that?
I also just want to say that Kimberly Sue pointed out that medical folks talk. That's what I guess it's exactly what I mean by peer-peer. Doctors talk well with doctors. So also, if that seems helpful, please take Kimberly Sue up on that offer as well. I really agree that those folks hear things differently from their colleagues than from a rowdy activist who's already developed a reputation of being a rowdy activist. In terms of a media plan, I'm not exactly sure what to say about that, other than I know that there's some conversation with several different journalists who are interested in this. There hasn't been a huge amount of media on this, but I expect that to perhaps change. I know that Morgan's on the call. I don't know if perhaps you might want to say anything about that, Morgan, or I don't need to put you on the spot there.
Yeah, so I just I pitched a piece. I'm writing a piece for Filter about this, and I would love to talk to someone directly, like harm reduction orgs that are going to be directly affected by this. And the distribution angle too, I would also probably like to include that. So it's just sort of like a misallocation of resources more than a literal shortage. So if anyone wants to talk to me, message me. And yeah, I'm hoping to have that out this week.
Sorry, was that Morgan Farrington?
Morgan Godwin. Hi.
God, thank you. I just couldn't find her name for a second.
I guess I was asking also just for an update on, we should be keeping that we should be keeping this on the down low still with any big agencies, hospital. Like, I guess this ties into that hospital recommendation, is that I'm a little confused because in conversations that I've had with folks, we didn't want to necessarily let those folks know, because then they would panic and then would post large orders with Pfizer. but then also I mean, at my agency, we're keeping it, as needed to know, strictly. And just, will there be direction from OSNN when that needs to change, or, will OSNN reach out to us for support with that if they need it?
Christopher, I will say that earlier on, since we've known about this since early May, there was a time period where we were kind of hoping that our little rowdy, small but mighty group would be able to beat the rush to places like Direct Relief, etc. At this point, I think that anybody who has who thinks that there's a strategic advantage to talking to any media at any time, do whatever you feel is appropriate and strategic. I would, however, just remind folks who are part of the Buyers Club that there are components of your contracts that are covered under a confidentiality agreement. But anything that's not, whatever makes sense. So.
Also, Chris, Vi and I will continue to send out the weekly-ish updates, and especially if there's new news. So hopefully we'll make sure that everybody stays in the loop. We don't get a whole lot of new information from about this situation, but if there is any new information, we'll make sure that the Buyers Club programs are all kept in the loop. And it's a good point about hospitals. Hospitals are by and large the biggest users of generic injectable naloxone. Of course, it's used for anesthesia, it's used for veterinarian offices, it's used on ambulances. I mean, there's a much bigger market for hospitals, and it is a little concerning if they do all figure out about the shortage and start placing giant orders. However, I don't believe that the hospitals get the same price deal as us, and so they can also probably just order from some of the other generic injectable manufacturers, none of whom are also experiencing a shortage. So Mylan and Westbrook or whoever, all the other manufacturers of this exact same product can probably supply hospitals just fine for right now. We are just locked into this one company because they're the only ones that give us the affordable price.
Well, I do recognize that we have a little bit more time allocated for this, and always glad to stay on and have these conversations, continue having these conversations, but also know that people are busy, and clearly there's a lot to be done and a lot of work to do. And so don't need to pull this, extend this out any longer unless there are any additional questions or comments from any of the panelists or folks in the, in the room. So yeah, I'll just say I really appreciate all of this coordination and all of the coordinated efforts at all levels, especially from Maya and Eliza and other partner organizations at the national level, federal level, and obviously state level and program level. So NASDAQ really is always glad to help be strategic with you all at any of those levels. So feel free to always reach out if you have thoughts or follow-up questions or considerations or want connections. So really always pleased and grateful to be able to play whatever helpful role we can. So we are here if you need us.
I did perhaps also the NASDAQ might serve as a great sort of clearinghouse role for things like, I'm aware that organizations are starting to develop or revise educational materials in terms of like what to do during an overdose when there's no naloxone and things like that. I know that way back in the day before we all had access to naloxone, some of us had some of those materials about like what to do where there's no naloxone, but I'm aware that there's at least 3 off the top of my head that are developing those materials. So it feels like, you know, that also is a great role for NASDAD as like a clearinghouse to be like, who's working on this, and here's some updated stuff on that. So I appreciate your support in that way too. Thank you.
All right, anything else? Hearing none. Again, just appreciate everyone for making the time and space and all the effort on this. And really, Amanda, thank you for pulling together and working so closely with Maya and Eliza on these recommendations. I think it will be really useful. So hope you all have a lovely afternoon. And again, we're here if you need us, okay? All right, thanks everyone. Hope you have a great day. Okay, bye.